This is going to be like a really big video because this, my friends, is one of the most complex topics of CBS. You try to mug it up, but then in a few days, everything just vanishes from your brain. So I found a few mnemonics, a few tricks to just remember it, so that I can just at least rule out half of the options, and I hope it might help you too. So before we proceed with all of these systolic and diastolic murmurs and valvular diseases, there's something we should know. Okay, so I saw a reel somewhere on Instagram which gave me a pretty cool mnemonic, and it has made my life very easy to identify which one is the systolic murmur, which one is the diastolic murmur. So it goes something like this. You need to remember 4S. So it goes like this. The first S is septal defects, for example, VSD, right? And then stenosis of semilunar valve, that means AS and PS, pulmonary stenosis and aortic stenosis. So both these stenotic murmurs of semilunar valve and septal defects are systolic. Okay, and similarly, if the semilunar valve stenosis is systolic, then the regurgitant murmurs of semilunar valve, that is AR and PR, will be diastolic. Okay, and if semilunar valve stenosis is systolic, then stenosis of atrioventricular valve will be diastolic. That means MS and TS, mitral stenosis and tricuspid stenosis. Similarly, if the stenosis of AV valve is diastolic, then regurgitant murmurs of AV valve will be systolic. That means MR and TR. So this particularly gave me like the idea to rule out which one is systolic and which one is diastolic. It might take some time to just get a hold of this mnemonic, but once you get a hold of this thing, it's very easy to remember which is systolic and which is diastolic. And as you know, systolic means between S1 to S2 and diastolic means between S2 to S1. Moving on, let's start with the murmurs and everything. I'll be going in depth according to the USMLE. So let's start with aortic stenosis. What does stenosis mean? Stenosis basically means narrowing, correct? Sclerosis is thickening, whereas stenosis is narrowing. And the narrowing occurs usually due to age-related calcifications. So in older patients, mostly stenosis is in older patients. If it's in younger patients, it is due to bicuspid aortic valve calcification. Okay, and if we see the symptoms, it's basically sad. Old people are sad, so just remember it as syncope, angina and dyspnea, and these changes occurs during exertion. So what do you mean by exertion? So for example, patient is shoveling snow, lifting heavy bags, and while doing these exertion things, he has a syncope, that is loss of consciousness. And these symptoms usually don't occur until the stenosis is severe, that is valve area is less than 1 centimeter square. So we have discussed the clinical features and etiology of AS. Now coming to the presentation, I mean, what all signs and murmurs and everything do you see here? So I remember this crescendo decrescendo murmur. How do I remember this? I think of stenosis ka S. So you have the C. This is the S, right? So I break it down like this. This is crescendo and this is decrescendo. So I remember it like that. I find it easier this way. It might be silly, but it works for me. Where do you auscultate these? So there are 4 areas of auscultations. So it is A, P, T and M, right? So you can just remember it as Rose's apartment song, Apate Apate. So in the A area, you can listen aortic stenosis. In the P area, you can listen PS. In the T area, you can listen to TS and TR. In the M area, you can listen to MS, MR and MVP. And what about the ASD and VSD? Since you know atria come a bit higher, you can listen ASD here and you can listen VSD here, correct? And what about the AR and MR? So between the P and T, there's a point called Erb's point. Okay, this Erb's point, you can listen PR and AR. And along with this, you can also listen to HOCM here. One more thing that I did forget is there's another murmur of PDA, continuous machinery murmur, which you can listen to at this P point. And where are the locations? This is second intercostal space. Okay, these both are in second intercostal space. This is in fourth intercostal space, and this is in fifth intercostal space. And the E point, that is Erb's point, is between the second and fourth, that is third intercostal space. Okay, and aortic stenosis occurs in second intercostal space, correct? And there's something called supravalvular aortic stenosis. This is valvular aortic stenosis, then there is supravalvular. So this supravalvular aortic stenosis occurs in the first intercostal space. This supravalvular aortic stenosis is mostly associated with Williams syndrome. And Williams syndrome is basically the patient has Elfian face. And along with that, patient is hypersocial. So this is supravalvular aortic stenosis. Now if you think this is the right side and this is the left side, so the murmur of aortic stenosis can go and radiate to the carotids, and the murmurs of mitral thing can go and radiate to the axilla. This is carotid, correct? Radiates to the carotid. Okay, and one more thing that you have to remember is pulsus parvus et tardus. So tardus I think of as tardy. What does tardy mean? Late. So parvus is weak, okay, no power, okay, I think of it as low power, and tardus is tardy, that means late. So you have weak pulse and delayed, that is late peak. Now there is something called severe aortic stenosis, which is very important because this decides when we have to replace the valve. Okay, so let's go ahead with the criteria of severe AS. Okay, so severe AS means the jet velocity of blood, aortic jet velocity, is more than 4 meters per second. Valve area is less than 1 centimeter square. You need to remember this because they won't give questions with the jet velocity or pressure gradient or anything like that, but they do mention the valve area in the questions. So less than 1 centimeter square valve area is severe AS, and mean transvalvular pressure gradient is more than 40 millimeter mercury. So these are the three criteria for which aortic severe AS we can call the condition as severe AS. And what do you do if there are no symptoms in severe AS? Then you have to follow up with echo every 6 to 12 months. Okay, so what is the indication for valve replacement if you ask? These are the indications. So along with severe AS, more than or equal to one of the following should be present. That is, symptoms should be present, ejection fraction should be less than 50%, and if the patient is undergoing some other cardiac surgery, for example CABG, then you can perform valve replacement during this time. Okay, so for example, if supposingly the patient is high risk for this valve replacement, correct, or if the patient is critically ill to receive immediate valve replacement, then you can go for balloon valvotomy. Now what is balloon valvotomy if you ask? Basically they'll send in a balloon, correct, and then they'll separate the fused valve leaflets. Okay, they don't make a hole or anything, they just push the balloon in and separate the fused tip leaflets, which are narrowing the the valve area. Now there's another procedure called balloon valvuloplasty. Now what is balloon valvuloplasty? It basically widens the opening, but it may cause regurgitation. Okay, since we are opening the narrowed opening, right, it may cause regurgitation. Okay, and when is balloon valvuloplasty done? It's done in both young symptomatic and asymptomatic patient. For example, if the patient wants to get pregnant or participate in competitive sport, asymptomatic patient wants to get pregnant or participate in competitive sports, that is when you should consider balloon valvuloplasty. But the patient should have these three conditions. That is, patient has aortic stenosis. And when does young patient have aortic stenosis? If they have bicuspid aortic valve. And the second condition is there should be no significant AV calcification, correct, or aortic regurgitation. Next, peak gradient should be more than 50 millimeter mercury. These are the conditions for balloon valvuloplasty. One last point is chronic AS, means the afterload is chronically increased, and this will cause left ventricular hypertrophy, concentric. So the hypertrophy of heart is basically two types: eccentric and concentric. Concentric hypertrophy occurs due to pressure changes, whereas eccentric hypertrophy occurs due to volume changes. Okay, so we have LVH, concentric hypertrophy, and the left atrial pressure is also increased. So increased amount of blood in left ventricle, the pressure will be transmitted to left atria, and then this left atrial pressure is basically pulmonary capillary wedge pressure. Okay, so there will be increased pulmonary capillary wedge pressure eventually in the patient of AS, chronic AS. So this increased PCWP may develop into AFib. Now if the AFib continues, then that might cause two things. One is stroke, and another is heart failure due to loss of contraction. So this increased LAP might go to the pulmonary vein, and it might transmit as pulmonary edema. That is heart failure. There is another condition which is very similar to aortic stenosis, and it is called hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy, that is HOCM. Okay, HOCM, what things are similar with aortic stenosis? First, let's discuss that. First thing is crescendo, decrescendo, murmur. And there are maneuvers which increase the murmur intensity and decrease the murmur intensity, but then we'll discuss all of that at the end of this video. The next point is it occurs at Erb's point, just as we saw here. This point is the Erb's point, that is third intercostal space, and there is no radiation to carotid. There is radiation in aortic stenosis, but there is no radiation to carotid here. So we discussed briefly about HOCM. Okay, now this is like a very important table of the difference between AS and HOCM. Okay, so aortic stenosis, the murmur intensity decreases with decreased preload and increases with increased preload. So if there is large amount of blood that is passing through the stenotic valve, then there will be increased amount of turbulence, then that will cause increased murmur intensity. So if there is less blood, then that means the murmur intensity will decrease in stenosis. And if there is increased afterload, then the murmur intensity will decrease. Okay, and HOCM we have opposite. That is, if the blood load, that is preload, is decreased, then murmur intensity is increased. So what happens in HOCM is basically, in HOCM there is septal deviation, right? Because the septum is thick, it goes and blocks the valve opening. So if there is more blood, then this blood pushes aside the septum, correct? This pushed septum will now remove the obstruction from the aortic valve, and the murmur intensity is decreased. Hence, if there is more blood, the murmur intensity will be decreased, and if there is less blood, the murmur intensity will be increased. Okay, now both of them have S4. Ejection click is only present in stenosis. Carotid pulses, we saw there is pulsus parvus et tardus, right? Tardy, delayed. Here, the pulses are normal, that is brisk and rapid. One thing I forgot to discuss is the pressure volume loops. So aortic stenosis mein we know there is more pressure from the LV side when compared to aortic pressure. That's why the LV pressure is higher when compared to aortic pressure. And if we see this, there is increased afterload. And increased afterload means this goes up. That means the systolic volume and systolic volume increases here, correct? So there is increased end systolic volume, increased LV pressure, increased afterload, and decreased ejection because there is obstruction. Hence, there is a decreased stroke volume, because end diastolic minus end systolic is the stroke volume. Normally, it is this. This is the stroke volume, but now here the stroke volume comes down to this. Correct? This is the end systolic volume. This is the end diastolic volume. We have discussed AS, and if we think about PS, it's mostly same. Pulmonary stenosis is mostly same, but it is on the right side of the heart. It has the same murmur, crescendo, decrescendo murmur. But pulmonary stenosis is mostly congenital condition, or it is associated with carcinoid syndrome. And mostly the symptoms occur by adulthood. Okay, if the patient is asymptomatic in childhood, means it will develop symptoms in early adulthood. The pulmonary stenosis is like severe It will cause right heart failure in childhood only. And what is the management, if you ask? Since we have valve replacement, valvulotomy, valvuloplasty in AS, what is the management in PS? It is valvulotomy or surgical repair in some patients. Since we just completed the aortic stenosis and pulmonary stenosis, it would be better if we follow up with a regurgitant murmur, aortic regurgitation. Correct? So let's see what are the causes of aortic regurgitation. That is bare. That is bicuspid aortic valve. If you notice, bicuspid aortic valve is causing both AS and AR. Next is endocarditis. Next is aortic root dilation. Next is rheumatic fever. So this is the bare. Next thing, we remembered all these systolic and diastolic murmurs with the 4S, right? So stenotic murmurs of semilunar valve are systolic. So regurgitant murmur of semilunar valve will be diastolic. So regurgitant murmur is diastolic. And I think of regurgitant murmur, so if I break this, it is D, correct? So I remember this as regurgitant murmur is decrescendo murmur. So it keeps decreasing here, okay? And since it's diastolic murmur, it starts after S2. So you have diastolic, decrescendo, and high-pitched blowing murmur. And we discussed that AR occurs at Erb's point. Correct? Here you have AR. Erb's point is left sternal border. In aortic regurgitation, the main thing you have to remember is the hyperdynamic pulse. Okay, so it is very important because there are so many signs and things you have to remember in aortic regurgitation, and all of them are like really important. So there is head bobbing, you can see, and on auscultation it is called as D Musset sign. Okay, and then there is wide pulse pressure. It's very important, wide pulse pressure. Then there is pistol short femoral pulse. On auscultation, it is called as Traube sign. There is pulsating nail bed. It is called as Quincke sign. Then there is water hammer pulse. That is rapid rise and fall of what happens in the aortic regurgitation. This is the aorta and this is the left ventricle. So the blood keeps falling back in the left ventricle. So the LV and diastolic volume keeps increasing. Okay. So basically the forward stroke volume here in the aortic regurgitation is decreased. So what happens? There is compensation. What is the compensation? There is eccentric LVH. If there is a change in LVH due to pressure, then that is concentric. If there is a change in LVH due to volume, then it is eccentric. So in aortic stenosis, because of the constant pressure to push the blood out, you have concentric LVH. Here the blood keeps falling back. To accommodate the volume, the left ventricle dilates. So this dilated thing is eccentric LVH. So now because of this eccentric LVH, the stroke volume and systolic blood pressure are maintained. But eventually what happens, the dilated LVH, this compensation fails. So when this compensation fails, the left ventricle fails to contract. There is decreased contraction, which eventually leads to decreased stroke volume and heart failure. And you also have S3 present here. If it is acute condition, acute AR, since there's a lot of blood that keeps falling back, there's a lot of blood that keeps falling back into the left ventricle, so there is no compensation at this point. So what happens, the LV pressure is transmitted to left atria, right? The blood from left atria goes to pulmonary vein, and from there it goes to lungs and causes pulmonary edema. So in acute AR there is no compensation, and this happens. In chronic AR there is compensation, and when this compensation fails, you have heart failure. In aortic regurgitation, the blood keeps falling back into the left ventricle, correct? So there will be increased preload. So your graft shifts this side. And you have large pulse pressure. So diastolic BP is the start of this point, systolic is the start of this point. So you have a great difference. So wide pulse pressure is there, dicrotic notch is absent, and there's rapidly falling aortic pressure. There is pulmonary regurgitation. Pulmonary regurgitation, most of the things are same as aortic regurgitation, just that it is on the right side of the heart. So if there is right heart dysfunction, then pulmonary regurgitation occurs. Okay, pulmonary regurgitation may we have right ventricle hypertrophy instead of left ventricle, which eventually develops into heart failure, just like left side, correct? There is dilation and then heart failure. Okay, and when the dilation occurs, you have parasternal heave. That is, you can, right? And what are the causes? There's rheumatic heart disease and endocarditis. Both can cause pulmonary regurgitation. What is the management? You have to do echo, and if symptoms are present or if you start to see the dysfunction, right, you can do the valve replacement. Next comes mitral stenosis. What did we say stenosis was? Stenosis was narrowing of the valve, correct? So according to the 4S mnemonic, if there is stenosis of the AV valve, it is the diastolic murmur. Here, it is the AV valve, that is atrioventricular valve, and stenosis happens. That means it will be diastolic. So, what are the causes of mitral stenosis? So, mitral stenosis can be due to two reasons. Okay, first one is just as we discussed about aortic stenosis, it is age related, correct? So mitral stenosis can also be age related. The second thing is the most important one, rheumatic fever. Okay, so the questions will be like, young female, she used to live in India, she used to have recurrent throat infections and stuff like that, right? Strep infections and stuff like that. Then your first thinking should go towards mitral stenosis. Okay, so there are two reasons, age related, and second one is rheumatic fever. Another thing that you have to remember here is that pregnancy precipitates mitral stenosis, because see what happens in mitral stenosis. Okay, so here is the mitral valve between left atria and left ventricle. So what happens is there's narrowing in the valve, correct? So the blood won't be able to go to the left ventricle, so this process is stopped. That means blood keeps remaining in the atria. Now this blood transmits the pressure from left atria to pulmonary vein, and this pulmonary vein goes to the lungs. Now there's increased pressure in the lungs, and this will cause pulmonary edema. So when there's increased left atrial pressure, it is pulmonary capillary wedge pressure. So the increased pressure in the left atria is transmitted to the pulmonary vein, and then it goes to the lungs where it causes lung edema, that is pulmonary edema. And from lung, in the chronic stages, it is transmitted to the right side of the heart. Okay, so this is pulmonary artery, so you will have pulmonary artery hypertension, correct? And this hypertension will eventually develop into RVH, right ventricular hypertrophy. Now since the ventricular hypertrophy here is due to the pressure, not the volume, correct? So this will be concentric RVH. Okay, so you'll have RVH, and when this fails, you'll have heart failure. Another important thing that you have to remember in mitral stenosis is mitral phases. There are pink purple patches on cheeks. One thing that I always used to get confused about mitral valve is opening snap. It was very difficult for me to distinguish earlier that opening snap occurs in mitral stenosis or mitral regurgitation. So I came up with this mnemonic to help me differentiate that. So you have stenosis mein OS, that means opening snap is in stenosis. So what exactly is an opening snap? So during diastole, your left atria has to pump blood into left ventricle so that it fills. So how does it happen? Your mitral valve has to open. So when this mitral valve is opening in diastole, there is an abrupt halt in the leaflet. After initial smooth opening, after rapid opening, there's an abrupt halt due to fusion at leaflet tips. So I'm just demonstrating the left heart over here, left atria and left ventricle. And now during the diastole, the leaflet has to open, correct? So now there is a fusion at the tips here. So initially, after opening a little bit, due to the fusion of the tips, it comes to a halt because it can't separate from the tip. So it is halted like this. It can't separate because it is fused here. For example, let us say that there's a calcification or something, and it is fused here. Initially it opens, and this is the limit. After this it cannot open. So that is the reason why you have abrupt halt in the leaflet motion after rapid opening due to the fusion. This is called opening snap. So now what left atria does is it keeps pushing, keeps applying pressure, right? That's why the left atrial pressure is much higher than left ventricular pressure during the diastole. This is what is opening snap. So mitral stenosis has opening snap, and there's delayed rumbling, mid to late murmur. And the The distance between the S2 and opening snap determines its severity. So for example, if the OS occurs at a greater distance from S2, right? For example, OS occurs here, that means the severity is low. Okay, but OS occurs like immediately after S2, that means the severity is high. So the closer the distance, the higher the severity. Now let's discuss some of the consequences of chronic MS. So what happens in chronic MS? The chronic MS, the blood keeps emptying into left atria, but left atria is unable to empty into the left ventricle. So due to the volume overload, the left atria has to undergo some compensatory mechanism, so it dilates. Correct. So there's left atrial dilation. Now this left atrial dilation can go and compress recurrent laryngeal nerve. Okay, so it might lead to Ortner syndrome, and the symptoms will be hoarseness. In addition to that, the pressure from left atria is transmitted to the lungs, so there is pulmonary congestion. Eventually, due to the dilation and everything, the atria cannot contract, so it will lead to atrial fibrillation. AFib, loss of atrial contraction. Now this atrial fibrillation can throw out thrombus. We have already discussed here, if the pressure is transmitted to the right side heart, you will have right heart failure. So when left atria is dilated, there's upward displacement of left bronchus. Okay, left main bronchus is displaced upward. And another thing is pulmonary congestion leads to orthopnea, dyspnea, and paroxysmal dyspnea. Now, if we see the PV lobes, in the mitral stenosis, since there's no emptying into the left ventricle, the preload decreases, correct? So you have decreased end diastolic volume, the graph shifts this side, okay? And if you see, the left atrial pressure is much higher when compared to left ventricular pressure. And there's pre-systolic accentuation present, okay? Semilunar valve stenosis is systolic, then regurgitant of AV valve will be systolic, correct? So these are systolic murmur occur between S1 to S2. I think of it as regurgitation means there's like a hole that keeps leaking blood into the left ventricle, left atria. Correct? Left ventricle say you have blood leaking into the left atria. So I think of it like a hole. So there's a holosystolic murmur. Okay, it's lame, I know, but then that's how I get by. It is holosystolic blowing murmur. Or else if you want, I also think of it like continuous M. So it's like mitral regurgitation will have continuous M's, holosystolic throughout the systole. Okay, and we saw here that mitral occurs in fifth intercostal space and radiates to the axilla, correct? In AS it was radiating towards carotid, and regurgitation it's radiating towards axilla. So same here, loudest at the apex, radiates towards axilla. And let's discuss the causes of MR and TR. TR is mostly due to IV drug abuse. Second reason is due to RV dilation. Okay, now let's see about MR. What are the reasons for mitral regurgitation? The first thing first is ischemic heart disease. That is post-MI mitral regurgitation can occur. So how does it occur? There is three mechanisms by which post-MI MR occurs. So these are the three reasons why after MI there might be mitral regurgitation. So first thing first, that is in the immediate phase of MI, post-MI, papillary muscle might get displaced. That is why you can see MR. Second reason, it might take days, 3 to 5 days. Okay, so it can cause papillary muscle rupture. Okay, the third reason is LV aneurysm. This takes days to weeks. Okay, so these are the three reasons why MR can occur. And the other reason for MR is MVP, LV dilation, aneurysm or something like that, and then rheumatic fever. So if we talk about the mechanism of how MR develops, basically there is LV and diastolic volume increase. So this will cause the dilation of annulus of mitral valve. and this dilation will stretch the chordae tendineae, and this will cause insufficient closure, and this leads to mitral valve. So if you are wondering how this appears, so this is your mitral valve. It has 2 leaflets, whereas tricuspid has 3 leaflets. So you have the anterior leaflet here, okay, you have the posterior leaflet here. This is the annulus, this is the chordae tendineae which hold it in position, and these are the papillary muscles. Okay, so when the end diastolic volume increase, there's a dilation of annulus. It keeps stretching like this. Okay, this dilation causes stretching of chordae tendineae. Okay, acute MR, the left atrium size is normal. So when the blood keeps filling the left atria, okay, so this is left ventricle, this is left atria, the blood keeps flowing back into the left atria. So there's excess amount of blood in left atria, but the left atrial size is normal. So it can't stretch to accommodate the excess volume. So what happens? There is increased left atrial pressure, that is pulmonary capillary wedge pressure. Now this can transmit to pulmonary vein, and this can go to the lungs, right? It can cause pulmonary edema here initially. So this is what is happening in the left atrium. Now let's talk about what is happening in left ventricle. So with each systole, there is increased blood from left atrium. With each diastole, sorry. This causes increased end diastolic volume and end diastolic pressure. So when the systole occurs, LV should push blood out through the aorta, correct? But then it keeps pushing most of the blood back into left atria. So instead of pushing here in aorta, it keeps pushing back into the left atria because it is the easy way out. To push blood out of aorta, it requires more pressure, more force. But to push back into left atria, it is like the least resistant path. So it keeps pushing there. So what is the result? There is decreased afterload. And since there is decreased blood going to the aorta, there is decreased cardiac output. Okay, so if we see the stroke volume, it is increased because stroke volume is end diastolic volume minus end systolic volume. So the end diastolic volume is increased and hence stroke volume keeps increasing. Now let's talk about chronic MR. What happens in the left atrium and what happens in the left ventricle? In left atrium, there's accommodation for the blood, so there is compensation occurring. There is left atrial size increased. Okay, enlargement is present. So this enlargement causes decrease in left atrial pressure. So that means when the left atrial pressure is decreased, there's no transmission to pulmonary veins, then there's no pulmonary edema. Okay, so no pulmonary edema. That is decreased pulmonary congestion. But then over time, the blood keeps increasing and everything. Even this compensation is not enough. Okay, the enlargement is also not enough because atria stops contracting after a period of time. So what happens is over time, there is increased left atrial pressure, which again causes increased congestion. Then you have symptoms of pulmonary edema. Now let's talk about left ventricle. Okay, so left ventricle mein you have chronic overload. Correct, and this overload is due to volume of blood. So volume of blood, whenever it happens, there is eccentric LVH. Okay, this is the compensation, correct, and this is temporary. So if the volume is increased, that means there is increase in diastolic volume, that means there is increased stroke volume, that means there is increased ejection fraction. So but then again over time, like the left atrial thing fails, here also over time there is increased wall stress, right? Then this leads to contractile dysfunction. And this dilation, whatever this happens, there is dilation here, and this dilation causes S3. Important point because S3 determines the severity here. So when there is contractile dysfunction, your cardiac output and stroke volume and ejection fraction, all of it decreases. That means it comes down to heart failure. Okay, so let's see the hemodynamic changes in MR. So there's acute MR, there's chronic MR, there's compensation, and there's decompensation. In all of these things, you have a increased preload. Okay, because in acute MR, it's basically very severely increased, but then in compensation, there's a bit of management and everything, so the preload is not that high, but then it's high. Then if you talk about afterload, so in acute MR, the afterload is decreased. In compensation, the afterload might be decreased or might be normal. Okay, but in decompensation the blood is unable to push, so the increased pressure is required to push it, so the afterload keeps increasing. Next comes contractile function. There's no change in compensated and acute MR, but in decompensated, contractile function decreases. Okay, ejection fraction is high. Okay, preload is high, ejection fraction is high here. Here, ejection fraction is high, but then ejection fraction is low because stroke volume is decreased here. Correct. Here also stroke volume is decreased. Forward stroke volume, because the blood is regurgitated back to the left atria. And here, there's no change. Normal. Let's see the surgical indication for mitral valve regurgitation. Okay, so in chronic MR, when do you replace a mitral valve? When, regardless of symptoms, if the LVEF is less than 60% and there is LV dilation, okay, severe LV dilation is present or LVEF is less than 60%, regardless of symptoms, go for the surgery. And then if the patient is asymptomatic and LVEF is more than 60%, symptomatic and less than 30%, valve repair success condition, surgery is to be done if successful valve repair. And one more thing is you should often prefer valve repair more than replacement, because replacement requires lifelong anticoagulation and there's repeat replacement needed after approximately 10 years. And one more thing, ACE inhibitors decrease afterload and mortality in these patients. So in severe TR, so you have the heart, this is right atrium, you have superior vena cava, and then you have inferior vena cava. And this inferior vena cava portal system se it is connected. Inferior vena cava is connected to the portal system, correct? So when there is increased right atrial pressure due to regurgitation, tricuspid regurgitation, blood goes into the inferior vena cava, and then you have portal hypertension, which will present as hepatomegaly, lower limb edema, and then from here you have superior vena cava se you will get jugular venous distension, correct? And one more thing that you will get is ascites, abdominal distension. Present of S3 determines the severity in MR. So S3 present means it is chronic MR. S3 not present means it is not chronic. Now let us look at the PV lobes. PV mein you have increased preload, so it shifts to the right. And here you have increased left atrial pressure, so you'll have tall V waves. Now coming to the last segment, that is mitral valve prolapse. So I just remember it as V, MVP ka V. Okay, so you have a click followed by crescendo murmur. Okay, so crescendo means increasing, right? So this is the increasing thing, and then there's a click here. So I just remember this mnemonic which the first aid has given. Chordae causes crescendo with a click. Okay, what is the cause of MVP? If you see, it is endocarditis, infective endocarditis. It can be caused by rheumatic fever, chordae rupture, or myxomatous degeneration. So this rheumatic fever, rheumatic fever mostly affects the mitral things. Okay, then there's chordae rupture. So as we know, this is the chordae tendon. So you have rupture of this chordae tendon. Okay, and there's myxomatous degeneration, primary or secondary to connective tissue diseases. Connective tissue mein you have Marfan, Ehlers-Danlos syndrome, and then osteogenesis imperfecta. Okay, these are the diseases that cause MVP. So you have late crescendo murmur with click that occurs after carotid pulse, and you know where you can hear MVP, that is the fourth intercostal space. So let's talk a bit about the chordae tendineae rupture. So when this chordae tendineae ruptures, the leaflet becomes frail, it keeps moving like this. And what happens due to that? There is mitral regurgitation. And so I think that concludes most of the murmurs. If you remember this, then it is more than enough. And one thing I did forget is this, the maneuvers that increase and decrease the murmurs. So if you remember what is happening with the preload and afterload, and which murmur increase with preload and which increases with afterload, I think you're good to go. So let's first understand what happens to the preload and afterload during the maneuvers, and this will give you an insight of what condition increases the murmur, what condition decreases the murmur. So let's start with standing. So what happens during the standing maneuver? All your blood pools down in your legs, right? So when the blood is going to the legs, there's decreased preload. Okay, So all the blood goes down to the legs. There's decreased venous return, which will cause decreased preload. Next, think about valsalva, that is strain. So when you strain or do a forced expiration kind of thing, the intrathoracic pressure increases. So what happens when when there is increased intrathoracic pressure? So this will compress the veins in thorax and abdomen. So this will cause decreased venous return to heart, and this will cause decreased preload. Okay, this is what happens during this maneuver. What about passive leg raise? So what you're essentially doing is increasing the venous return to the heart. Okay, increased venous return to heart. Blood flows back from the leg to heart. What about squatting? Squatting compresses arteries and veins, right? So if you compress veins of what? When you squat, you compresses abdomen and leg veins, correct? So what happens due to the compression of veins? There is increased venous return to heart. And what happens when there is compression of arteries? Compression of arteries will cause vasoconstriction. This vasoconstriction will increase the systemic vascular resistance, which will cause increased afterload. Okay, so you'll have increased preload, increased afterload. Next, talk about hand grip. Hand grip also compresses veins and arteries in hand. This will cause increased afterload due to vasoconstriction. Next comes inspiration. Again, increases intrathoracic pressure. This will cause compression and everything, and this will cause increased venous return to right heart. That means there's decreased venous return to left heart. So this is what is happening, okay, during the maneuvers. Now what happens to the murmurs intensity? Okay, so most of the murmurs, if there is increased blood flow, then the murmur intensity will increase. If there is decreased blood flow, the murmur intensity will decrease. So when there is decreased preload, that is blood volume is decreased, that means most murmur will decrease, correct? Murmurs that decrease, most of the murmurs. Murmurs that increase with maneuver, that is increased preload and everything, most murmurs. Okay, you got till here. Next is increased afterload. So increased afterload will cause increased reverse flow across aortic valve, correct? So this will cause increased volume going towards this left side, correct? So most left-sided murmurs increase with this, okay? And similarly, when there is increased preload to right heart, right-sided murmurs increase. When there is decreased venous return to left heart, the most left-sided murmurs will decrease, correct? Because left heart is not getting more blood flow, that means left murmurs will decrease. Right side is getting more blood flow, right side increase. Left side getting more blood flow, left side increase. Now there is this exceptions of MVP and HOCM. So what happens to the MVP and what happens to the HOCM? Normally, if aortic stenosis and HOCM are both similar, then why do HOCM increase with decreased blood volume and decrease with increased blood volume? So what happens is in HOCM, okay, so this is your left ventricle, this is your right ventricle, and this is your aorta, which is getting obstructed because of the septum. And this is your left atria. This is your mitral valve. So what happens when there is decreased blood volume? The obstruction remains like this. Okay. When there is increased blood volume, the blood will push the septum this side. So when the septum is pushed this side, the obstruction will move from its place to here. So that means the murmur intensity decreases and blood smoothly flows from ventricle to aorta. That's why when there is increased blood volume, the murmur intensity decreases, and decreased blood volume, murmur intensity increases. So if you have the basic idea of all this, it will be very easy to remember which murmur increases at which maneuver.